we are gathered here this morning, some of us know, some may not know. Our great Sultan is here to talk to us. We have been trying our best in nursing education and practice as it is done in Nigeria here. We are doing well, but we can do better. Is that not so? Great educators, great lecturers, we can do better. So our sister is here to rub mind with us how it is done in advanced country so that we can improve on our own. So I'm introducing no other person than our very own. She trained here. We were classmates in School of Nursing. We entered the same time and we finished the same time. She has seen it on this other side and on the other side. She worked here for some years before she traveled out. Please let us be attentive and listen to her. I'm very sure we will get something from this lecture. You are all welcome. So welcome our very own Mrs. MABEL OKUNGBOWANUBTH. A round of applause.
Thank you.
You are welcome. Hello. You know that in every UTH gathering, we must say our core value. Please let's be on our feet for our core value.
So it doesn't matter where I stay. If I do this pointer even to there, will it work? Or it has to be to here? I can do that. Okay.
Thank you.
This is so humbling to stand before you, to address you about nursing ethics. When your provost came to me a few days ago, I wasn't even aware that we were going to do this. Precisely about 72 hours ago, she wanted me to do this. As a nurse, we should be ready anytime, any day. I don't know why you are a nurse. I don't know your motivations of becoming a nurse, but I do know why I am a nurse. Many people go into nursing because it's a lucrative job. Many people go into nursing, especially these days, because they want to travel abroad and go practice nursing. Because family members, somebody told them that if you are a nurse in the US or in the UK, you'll be paid big money. Maybe true. But if you don't have something inside of you that made you to become a nurse, you will never be a nurse that is caring at all. I was 12 years old in this country. My mother took me to the hospital, and you know, as a young teenager, I was being formed into a human being. And I received, the kind of treatment I received from the nurses who took care of me left an indelible mark in my soul. And I vowed to myself that I was going to become a nurse. And that when I become a nurse, I will not do what they did to me. I have referred to this in any of my writing. As I climb from one level of nursing into another, they want you to write a statement of why do you want to do this? And this has always been my story. I carried that for the rest of my life. That do unto others how you want others to do unto you. I got that principle when I was 12 years old. And that has guided my practice as a nurse. I am so proud that I'm a nurse. If I want to do life all over again in terms of profession, I want to be a nurse. Because in nursing, that is the only opportunity given to us to cry with your patient, to hold your patient one-on-one. There's no other profession. Even in medicine, they carry beepers. They are so time conscious. They just want to spend like 2 minutes with the patient, and they may even miss some diagnosis on the patient. I like practicing nursing in UK, for example, when you walk in the ICU, they really know how to practice one-on-one nursing. They hold their patient in the hand. They know how to treat a patient as a whole entity. And that is what is lacking in nursing in Nigeria. Oh my goodness. We are going to go into the lecture and you're going to see my own personal experiences in this country. As a matter of fact, yesterday there was an experience, last night. 3 days ago. My mother was discharged from the hospital here last week. So my experiences is countless. So I'm not even basing these references on other people's stories. So I understand it. It is inside my core. It's part of the blood that is circulating in my system. So when I say I know, you were trying to just let me know why we are here. No, I am a living testimony of the quality of nursing that we give to our people. Why is that? I don't know. Let's go to the lecture. Well, I guess I need to introduce myself a little bit. My name is MABEL OKUNGBOWANUBTH, Ni Omorogeva. I attended the School of Nursing here at UBTH. I was in the 27th intake, same like your provost. And I worked here in the Children Emergency Room from 1989 to 1994 before I left. You know, it's not easy to get employment in UBTH. But they had a thing in place then that if you are the best hospital finalist, is that still in place, Madam Provost? We need to put that in place. Because somebody like me who was born into abject poverty, there's something that will motivate people like that to make sure they get that, to become the, the best in the hospital final. And I was the best. I was so blessed. Thank you. So that was how I was able to make my way into UBTH. Otherwise, people like me, whose father was a carpenter, wouldn't be here, And along that same line, that is why we are encouraging our students with scholarships through Sonoda International. And we want these students to be very competitive and make sure they are the recipient of those scholarships. So it's along that same line. I'm a mother of 4 children by the grace of God, and I'm humbled to be called a wife as well. Nursing ethics. I told your provost that she's trying to put me in a position whereby I'm only going to give information, because nursing ethics is so big, humongous. This lecture is going to be like a spit in the ocean. You're not going to see it, right? So I've been thinking, how can we even make this few hours or few minutes of lecture become part of this system, other than individual commitment? You're going to have to think about whatever you want to take home from today's lecture and see how you as an individual can put this into practice. Otherwise, we're talking about a topic from the level of individuals to the departmental level, to the local government level, state, federal level. Everyone has to be involved in this, honestly. So it's not just, the nurses here are not doing what they're supposed to do. How can they do what they're supposed to do when they don't have policies and procedures in place? In Africa, when you secure an employment in a teaching hospital like this, it is like inscribed on stone. You are so sure that I will retire on this job and I will begin to earn the retirement money. It is not like that over there. Everybody has bosses ahead of them. So when you are in a job, you don't know what your outcome is going to be the next day, because they have policies and procedures. So, but because we practice who no ma here, it's not going to work. That is why, ethics. So it's from above. You see? So Ministry of Health, even the Minister of Health has a boss. See, that is the point. So the Minister of Health, or let's just say the Commissioner of Health, should not have a say to our Obaseki here, because this is his jurisdiction. That is how it's supposed to work. So because we don't have that in place, it is difficult. Because it's going to take one phone call from Obaseki to call me as a nurse, the head nurse of my unit, and say, Mabel, what are you doing to my girl on your unit? Do you see that it won't work? It's not going to work. It's not going to work. So if I have the capacity as the head nurse of B3, when I get that phone call from Mr. Obaseki, I walk ahead of him. I go ahead of him and talk to his own boss. I say, listen, he's meddling with my position. That is the only way it works. That is how it works over there. So that is why I said this is going to be a spit in the ocean. Other than what you want to take home, just think, who am I, a nurse? If you can define that for yourself, then hold on to that and practice nursing. The philosophy of nursing. I decided to bold some things there. Nursing is committed to and accountable for safe interprofessional practice as evidenced by consistent utilization of the nursing process, collaboration with our colleagues, and achievement of quality outcomes. We are advocates for people by promoting the delivery of the right care and at the right time. Think through those things that are bolded there. Commitment. Ask yourself, how committed am I to the patient in front of me? Are you really committed? Just think about it like a marriage, like a relationship that you have out there with other people. How committed are you? How committed are you to this patient? Remember, we all can be patient anytime, We all can be sick at any time. It's part of humanity, right? So the fact that I am on the giving side here and you are on the receiving side as in my patient shouldn't make me feel like I'm the God right now. Okay? So commitment. How committed are you in your practices to the person who is sick in front of you? Accountability. The practice of nursing here, we are not accountable. Why will I be accountable if nobody is going to question me? You see, that is the problem. Because we don't have policies and procedures in place. Even if we have them in place, are they being enforced? No. So, in order to practice nursing that is, whereby you are very conscientious, there is something I personally call policing. Policing. But in this environment, who is going to police who? You. There's something called conscience. Your conscience. Oh my goodness. My Mrs. Agawa, where is she? She taught me. Thank God she's still alive. Oh my goodness. As far as I'm a nurse, I remember Mrs. Agawa every day. Can you imagine that I say every day? Because every day that I practice nursing, Mrs. Agawa beat that thing into my core. And I remember her. Where is my bedpan? It's still on the way. Mrs. Agawa taught me that when you carry a bedpan, you carry with pride. Dignity. My goodness. She so described it that you would think that what is inside the hot bedpan is a dessert. A dessert. And I'm very serious. So since I come across patient BM every day, I remember Mrs. Agawa every day of my life. See? Pride. She will take that bedpan and she will walk like that. I love that woman. Another thing she taught me that I would never forget, we'll say in the lecture. So, patient advocate. Advocate. Do you know the meaning to be a patient advocate? When I go into my experiences in this country, or some of the scenarios that we need to go through, then you begin to see what it means to be an advocate. The right care. Do you believe there's a wrong care? There's also a right care. The way you are taught in school, those principles that is surrounding all the 3 years training that we went through, there's a right way to care for a patient by not cutting corners. This is the vision of our founders. Excellence in human caring. You know, every one of us want to be treated so well. In fact, if the Governor Obaseki, let's just say the wife needs to be admitted to the UBTH. Oh my God, he's going to look for the best matrons, the best doctor. As a matter of fact, they might just assign the best doctor one-on-one, 24/7 to cater for this loved one. Why is that? Why? What happens to equality? Why can't we diversify that to everyone that we take care of? Why must we select it for selected people? Why? We all want to be cared for. That human caring, that human touch is what our founders wanted when they founded nursing. So let's define ethics. What is ethics? It spans from the Greek word ethos. It means a way of living. For example, in my home, my way of living, you can turn off the light in my home, I'm in total darkness. I will walk through my home and I will be able to identify where the bathroom is, where my kitchen is, exactly where I put my knives in the kitchen. There is a way, structured way of living in my home. That is how nursing is supposed to be. Okay? So that is ethics for you, a branch of philosophy that is concerned with human conduct, more specifically the behavior of individuals in the society. Ethics are moral principles that govern how the person or a group will behave or conduct themselves. So there's something people don't understand. It doesn't matter how you treat your patient in the hospital. To me, that is the way you are in your home. Have you heard about marriages falling apart? Yes. You see, if you are born again to the point that you give nursing care to a total stranger with commitment, advocacy, all that, listen, that same spirit is what you bring into your home to take care of your husband, to take care of your children. You know, it works out nicely. If you are a bitch nurse in the hospital, you bet, maybe 95% of the time you are bitchy to your spouse. You see? So, because it's not possible for me to be one thing in my home and another thing out there. No, you are you. You are who you are. See? So, you might as well be a nurse everywhere you go. So, the second thing Ms. Sagawa taught me, which is lacking in nursing, is conscience. Oh my goodness, that lady taught us sterile technique in doing wound dressing. Ms. Sagawa said, oh yeah, they just brought my bedpan and my dressing kit. How many times do we even have to wash our hands before we do sterile dressing? What is the minimum? So, assuming this was a sterile dressing kit that Ms. Sagawa was telling us to, we will wash our hands. We'll come back and open the outer layer. We'll go wash our hands until you get to that inner layer, and now you are about to don your gloves. She said, when you pull that curtains and you are left with that patient in that room and you want to carry out this sterile technique, you are the only one there. Assuming your patient is an invalid. Assuming, this patient is just mentally, incapacitated. It is you and this patient. He or she cannot tell you anything otherwise. This is how Ms. Agawa said this thing. So he said, and you know that before you don all your sterile gloves, you do know that you contaminated something in that pack. You know, it's between you and your conscience. are you going to carry on with that dressing? These days, we just feel like nobody's watching me. I can do whatever I want to do. As a matter of fact, they might not even wash their hands. And there's a way to wash your hands. I'm not talking about washing your hands without soap. I'm not talking about washing your hands for 5 seconds. You have to follow the rule of hand washing. That is when, in those days, we don't wear nail polish, okay? We don't wear long nails, because we got to wash those hands and get into those, underneath the nail bed and make sure we are really clean before we don on that gloves, the sterile gloves. That's how much your internal police officer. So she beat it into my young head, and I carried it for the rest of my life. So I know there are professors here, the teachers of the school here. So it does matter how you teach people, okay? Whatever they want to become tomorrow, you may have an impact. Agawa had an impact on me. Whether we like it or not, your young students, I'm sure probably they are below 26. Their hearts are still young. Beat it into them. Let them carry that conscience with them. Because it does go a long way. So that is my Miss Sagawa. I love her to death. A brief history of nursing ethics. The onset of nursing ethics can be traced back to the late 19th century. At that time, it was thought that ethics involved virtues such as physician loyalty, high moral character, and obedience. As you can see, I highlighted physician loyalty. Unfortunately, the best we can carry in this definition is the physician loyalty. That's it. What happened to the rest? Africans know how to be loyal when it comes to the doctors. I'm sorry to say I'm not discriminating right now. Okay? Why is that? Why is that? As long as that person is a doctor, that's it. Because you fail to advance your career. You fail to equate your... I know that these days, you all have different degrees that you are pursuing here. But it looks like those credentials behind your names, that is where it ends. What about the transformation they were supposed to do in you? Okay, you were supposed to advance yourself and come back and start collaborating with them at the same level. That is what we do out there. Okay? The doctors, we see the nurses as colleagues. Colleagues because we are talking the same language. Okay? When they are talking about, action of medications at the cellular level, that is the level we are going to communicate. We're going to be talking about receptors. Okay? So when you liaise with them like that, you gain your respect. You gain your respect. You're not going back to school just because you want a promotion. That is not why we go back to school. You want to go back to school and become transformed. So that when anyone interacts with you, they will see that you are educated. I mean, educated. There should be a difference between a diploma and RON and a bachelor's. When you go back to get your master's, there should be a difference. As a matter of fact, when you go back to get your PhD, there is a reason for that dissertation with your PhD. When the doctors see that, you are so transformed. We used to have, there is a lady when I worked in children emergency here. This lady, then they had reserved starting an IV for the doctors and the house officers. So as nurses, we were just like so timid. I've forgotten this lady's name. She was the only one that was starting IV on those little pediatric kids. She was highly respected because she did that. I never knew that nurses could start an IV until I got there. When I got there, I was shaking. No confidence. Okay? So I had to go through that 6 weeks of orientation before I started knowing how to start an IV. Why? Why? Why can't you start an IV? There is something called the nursing process. So this is the reason why you are being looked down on. Because you have a degree, but you don't back it up, that you know what you're talking about. So I'm challenging my nurses, my student nurses. Okay? You all need to change nursing for us. You need to change it administratively and clinically. because we are on our way out to retirement. So it's your turn to change the nursing for us. As part of our history, as part of the history of ethics, these standards we are talking about is non-negotiable. Okay? You cannot negotiate it. But our culture in Africa, somebody can make a phone call and change it from his bedroom. This is why it's not working. Okay? If madam, you are the head unit, head of your unit, and your subordinate over there disrespected you don't want to do what you want her to do, or you were trying to just enforce the ethics of nursing, and now you end up getting a phone call from somebody's bedroom, you're just going to say, to hell with all of you, and I won't talk to anybody anymore. See, this is how we got to where we are today. People are meddling with our nursing care from their bedroom because they have godfathers and godmothers in places. That is why people are not listening. And it's going to take the grace of God to be able to change this. But you got to be from the head, not what we are doing right now. This is just informational. Because if you go back to your word and do what I'm telling you to do now, you'll be sacked. So look at this. We have 7 nursing ethics that we must adhere to. I'm going to read every one of them because this is crucial. And I think the PowerPoint will be available. You can go ahead and print it out if you want. These things, that is the summary. What is my, okay, she's gone. That is the summary of what we are talking about, nursing ethics, your attitudes, your behaviors and all that. Justice, beneficence, non-maleficence, accountability, fidelity, autonomy, and veracity. Justice, the right to be treated fairly and equally, where if that decision is compatible with the law, the patient's right, and if it's fair and balanced. What are we weighing? We don't have anything to weigh in Africa. Do we have a law? We are lawless. As long as we are lawless, we can't do anything about anything. Okay? So everything there, treat fairly. You want to be treated, everybody want to be treated fairly. But when it comes to treating other people, that's where the problem is. You see, what happens to do unto others? This is the only place whereby you're driving on that road, okay? And you are in the front driving. Somebody hits you behind. That same person who hit you behind comes out and says, you don't crazy? You don't crazy? You don't go move? No say go move. Excuse me, you just hit me in the back. The driving school taught me that 90% of my concentration is up front. 10%, I will be watching my rear view and my side view mirror, looking at the back. 10%. That is why in the advanced world, it doesn't matter what I did in the front. You are wrong. Okay, you will be wrong. You'll be so wrong that you are going to fix my car and your insurance is going to go up. So we don't have a law to uphold. That is a problem. Even if we have it, it's not enforced. It's a problem. Okay? So that goes our justice. Beneficence. Refraining from maltreatment, minimize harm, and promote good towards the patient. An act of charity, mercy, and kindness. These are, you know what is so outrageous in this country? Before I left, we know major churches like Church of God Mission. You could tell, and you can just pinpoint where you have all these major churches. Now we have it in every intercessions. Yet, see, this is nothing we are talking about. We are talking about what? Where is the thing? Charity, mercy. I thought those are virtues that is being taught in the scriptures, right? So if more than 98.8% of the population is going to church, let us start from there. And you are taught those virtues in your congregation. You have nothing right now in your life that will help you practicalize this thing, isn't it? Why are we not doing it? So that means we are two faces. We go to church and listen, but we don't enforce it in our lives. And that is why we also have so many marital issues. Because if I treat my spouse with respect, mercy, kindness, love, there is no way that man will not love me. There's no way. He must love me. People want to be treated differently, but they don't want to treat others the way they want to be treated. You see, we have a big problem, and it's affecting us as a whole. Remember, the whole, the body, the soul, and the spirit. We owe our patient that they need to be treated as a whole entity. We don't even do one, talk less of the whole. No maleficence. Patient has the right to no harm. Requires that every medical action will be weighed against all benefits, risks, and consequences, occasionally deeming no treatment to be the best treatment. Okay? I don't know what it is, but I just feel like I don't know about our judiciary system, because we don't have, that people could sue you. Therefore, when you do harm, it doesn't go beyond the department, your department there. But these are human beings, and poor patients, they just accept it the way they, that you give it to them. But you're supposed to not do any harm to your patient. Let me tell you. Remember Mrs. Agawa sterile field? Let me stretch it a little bit so that you can see how you do harm. You contaminate. You've contaminated your dressing. Okay? This patient is diabetic. Okay? Then the wound now, you decide to introduce those bad bugs like MRSA. Okay? Now, in the presence of infection, the sugar is going to go way up. Now, with hyperglycemia, this patient wound refuses to heal, assuming the wound was right here. Okay? So with time, the toes become necrotic. Okay? And then from there, we proceed to come and do either a BKA, below the knee amputation, or AKA. From doing that, well, it's okay. You move on with your life. Now patient is going, does not have one limb because of you. Will you like it if your mother was amputated because of one silly mistake that I made? Is that a fair treatment? If you had an accident and you made it to my hospital, and I am your nurse, and you are just like 28 years old and life is about to start for you, and you get amputated, what would that do to your person for the rest of your life? There is a sin of omission, and there's also a sin of commission. Okay? So you can tell me where that falls under. So this is the impact of what we are doing when we are not, attending to our patients the right way. So do no harm. It's not. So I need you to start thinking about whenever you touch your patient with anything, it can be anything. I've seen them brought a cotton wool with alcohol, and they just walk straight to the patient and wipe and give. The alcohol that you brought with your cotton wool balls, is that really alcohol? These are the things we're doing, we're not processing them. Is that really alcohol? Alcohol is supposed to contain like 70% of alcohol, whatever you're wiping with. So when you open an alcohol bottle, do you date that bottle? Do you date it? You don't. You just keep using it until you finish it. So which means the potency of that liquid is down. And why did you use it in the first place? You wanted to make sure, like the staphylococcus organism on the skin, right? You wanted to reduce them before you give your injection. But you did not really wipe. You wipe the patient arm with water. Water. That is what you use in wiping the patient arm. And now what? You take your so-called sterile needle to push what is on the skin into the patient. You wonder why nosocomial infection is so big in the hospital setting. Do no harm. Do no harm. Don't throw a stone into the marketplace because it might hit your own mother in the eyes. Do no harm. So we are not processing the impact of our nursing care on the long run on our patients. This is what we're doing. Okay? Fidelity, accountability. To take responsibility for one's action, decision, and all that. Even if you catch somebody doing the wrong thing, their consciences are so blunt. They don't even feel remorse. What are we doing? Where are your conscience supposed to be your internal police officer to keep you in check as you carry out this nursing care? If that is gone, then you are not a nurse. I'm sorry to say. You are not. So you need to nurture your conscience. Whatever religious practices that you belong to, I am sure every one of them, they have something in common. Treat others the same way you want to be treated. It doesn't matter what religion you belong. Do that so that when you lay on your bed, you sleep and be peaceful. Okay? So that is very important. You need to be accountable. Accountability means that if you really did that thing and it comes to your conscience, own up. I'm sorry. I didn't think through that. I didn't know that would be the impact. I am so sorry. And now tell yourself, how do I change my practice? Because nobody else is going to change it for you. Fidelity. When I hear the word fidelity, for example, I just think about marriage. You know? So which means this patient-nurse-patient relationship is a marriage. It's a marriage. You see? So if you know what marital obligations are, that is what you're supposed to practice in nursing. Yeah, fidelity. Promise you, because so you have the promises. You are promised to provide high quality, competent, safe, and efficient care. That was what you promised to do when you graduated, as you are going through this program. See, so if you don't do that in your marriage, you're not going to do it to a total stranger. Autonomy, expressed as the right of competent adults to make informed decisions about their own medical care. That is just zero in this environment. Patients don't have any voice here. It's so pathetic, honestly. Okay? In the other world over there, if a patient tells you not to touch me, you don't touch them. A patient has the right to tell me, I want to speak to your supervisor. Okay? And she has the right to refuse me and say, I don't want MABEL to touch me. And I will be glad to quickly switch that assignment, because if anything goes wrong in my care, they will sue me and sue the hospital. Oh, my boss will be so glad to quickly switch that assignment just because a patient said, I don't want her to touch me. Maybe I've not even done anything wrong yet. Don't touch me. But we don't have any. If a patient here says, don't touch me, oh, she's not going to get the care at all. Oh my God. God forbid you said, don't touch me. I mean, your mother is coming from your home to come and take care of you. The nurses will start gossiping. What did she say she'd be? No. The patient has a right. A patient should be part of the nursing care plan. Okay? You have to include them. You know why? A patient wants, because I am a patient, I know how my body works. Okay? And I'm so glad, like I'm in anesthesia, I'm a nurse anesthesiologist. So I listen very well to my patient. They know their bodies. And I'm here handling all these little drugs that I'm going to use on them. A patient is the one to tell me, madam, I'm allergic to egg. Oh my God, once they tell me egg, okay, fine. I'm so grateful that they told that patient told me that. Because I know the content of propofol. What if she didn't tell me? What if I didn't make her comfortable to tell me? What about if it's in this environment? And propofol is the most common drug that we use to put patients to sleep. And because patients are timid, she or she's not part of my care, and now I give my propofol. And she develops anaphylaxis. What am I going to do? You see? So, excluding your patient, anyway, I know if the patient dies anyway, we don't even think we contributed to their death anyway. The patient have to, she died, that's it. Anyway, so, but if it's an environment whereby as you push the propofol, and and later you discover that this patient is allergic to egg, hey, you will not be able to sleep for the next 1 week. That's how bad my job is. You will lay on that. As a matter of fact, a patient dies on you. You did not even contribute anything to the death. You go there, you sleep, you wake up. What should I have done differently? Is what is going to keep me awake. I have tried to do what I'm supposed to do. But I am trying to bring that reason why this patient died. That is why in anesthesia, oh, no patient dies on the table. It's a no-no. You do whatever it takes to make sure every patient makes it out of your OR table. Okay? So involve your patient in their care. They know their bodies, how it works. Better than you, a total stranger. Listen to your patient. Veracity. The principle of veracity or truth-telling requires that healthcare providers be honest in their interaction with their patient. If you are so honest, especially in this environment of our patient population, they are very ignorant, and you become that nurse that your patient here can bond with truth-telling. If you did the wrong thing, or explain things to the patient, for example, the bond will be so strong. The patients here, they are so good that they feel they are indebted to you. I don't know about you. My only thank you, what gives me joy, is to see that my patient walks out of the hospital telling me, sister, thank you. There is no dollar value to that. Thank you. That's my joy of what I do. Yeah. Let's look at all the virtues surrounding ethics. Go through that in your own self and see if there's anyone you violate. If you violate any one of those, you violated it all. So it's like Christianity. The only one cut it, you're not going to make that heaven. Right? It's the same principle. Look at that. Integrity, moral principles, honesty, right, fairness, responsibility, conscience, choice, honor. Those are the byproducts of what we are talking about. If your practice is not surrounded with that, you need to be born again. If you have a religion of any sort, you need to go to that thing and begin to confess. And tell that thing, yeah, you just have to go back and confess it. So American Nurses Association, we do have a code of ethics. And they made about 9 provisions that they put together as a code of ethics. So that, you remember I was just telling you that because we are lawless, we don't have anybody that we report to, so therefore we just do whatever we want to do. So ANA had a code of ethics. One of them, the first provision, is that the nurse practices with compassion and respect for the inherent dignity, worth, and unique attributes of every person. Every person. When I saw a patient here, my goodness, in UBTH, left on the bed, naked. And I thought to myself, do we have nurses here who respect patients' dignity? Thank you. Because I don't see any one of us who will want to walk into where you admit your father or your mother and you met that person naked. Will you be happy? Oh, excuse me, you will not be happy. Well, we are so lucky we are in this part of the world where patients don't have voice. Over there, the family member, as a matter, you can't even do it because you want to make sure your patient is presentable. We also have some families, we call them troublemakers. Once you see them coming in, you want to quickly go to that room and make sure everything is in order because they will still pick up something. Talk less of meeting their loved one naked or in a pool of feces. It's a no-no. I just had an experience last week. My mother had hip surgery to take out the pain from her hip. So I was there all night. I was so tired. And I told the nurse that I was going back home to go change. My brother was going with me because he brought me to the hospital. The nurse said, Madam, no, you don't go. I said, what do you mean? She said, I had to leave somebody behind. Though. Either you go or your brother go. I said, my brother cannot go. I want to go, but I don't drive. He said, no, you go leave somebody behind. I said, okay. I said, but we live just around the corner there. I'm just going to change and come back and stay with my mother. So reluctantly, they set us free to go. Of course, you know our roads are so good, right? So I came back like after 2 hours. And then, as soon as, listen, I want to be crying right now. As soon as we came, we have about 6 nurses around the table, right? And, madam, you are late. You are late. I said, I'm so sorry. Oh, I told you before, as soon as you come out, your mother was asking for a bedpan. I said, oh, I'm so sorry, I didn't know. And the toilet paper, I said, the toilet paper was, before I could finish, that it was by the bedside table. She said, that's why we said you don't go away. You are not supposed to go away, because your mother was asking for bedpan. And I thought to myself, I thought bedpan, giving bedpan to the patient is part of the nursing care, right? And I'm thinking to myself, if I should just come and address this right now, I'm going to cause trouble. So I zipped my mouth. All I said to her was, I'm sorry. The road, I was explaining to her, the road was bad. That was why. Always leave somebody here. Nobody should be going. But you all are sitting around the table, talking. As a matter of fact, talking about me and my misbehavior. What happened to the bedpan that Mrs. Agawa talked about? This thing. What happened to a bedpan? That when you are wiping this patient's butt, you are smiling like you are about to eat your dessert. That's how Mr. Agawa described it. Okay? So what happened to the nurses giving bedpan to my own mother? Is that something too big to ask? Is that not part of your nursing care? Why are we Carloses now? What kind of nurses are we producing? And when I'm emptying this bedpan in the room where I'm supposed to empty it, as a matter of fact, it gives me joy. Is there anyone who goes to the bathroom here to do number 2 that doesn't stink? If it doesn't stink, there's something wrong physiologically, isn't it? You see? So there's something wrong with our practice. I was going to cry, but I could not cry. I was just saying, God, is there anything I can do to change this? Is there anything I can do to change this? And then here you are asking me to do this. It was just something I said, okay, now they have let the cat out of the box. We can't do that. We're dealing with human beings. Human beings. Or the nurse came to my mother in the same admission. She's coming with a syringe with her hand like this and alcohol like this. Madame, attends. My mother was like, I was just watching it because this was drama. For me, it's drama. She's violating this patient's human right. No explanation of whatsoever. And she finished jabbing her. I was holding her hand on that side. And she finished and then she left. I said, I quickly, low tone, I said, Mama, ask her what she gave to you. My mother said, Mother, now payment this to be done. This is what she did, honest to God. She was walking away like this. Yes. Listen, all of us, we are going to fall victim of this thing. Okay? It's not reserved for any specific family. If you think you're not going to be a recipient of this, I'm just telling you right now, my experience last week. Your family member is going to be part of this. But what can you do? If you make that decision by yourself and said, you know what, I'm going to take care of my patient with dignity, with conscience, okay? Whatever this I don't want done to me, I'm not going to let it be done to this patient. If you do that, somebody will recognize it. Oh, that nurse. Oh, that nurse. Oh, that nurse. Before you know it, it's a ripple effect. When you put a stone in the water, ripple effect, right? You begin to infect and affect the world around you. Or they were going to distribute medications for my mother. I don't know why they took this thing. The nurse poured all this Jesus, I'm telling you guys, the disparity between the nursing care here and over there is so wide apart. They put all these medications in a cup. Came to my mother and said, Madam, here, see your medicine. Like about 9 pills. I'm like, oh, what is she taking? Well, her medicine. I know that. I know there are medications. What is she taking? This is a woman who is diabetic. I have her pills already laid down. I don't know if they are going to be giving her another metformin, and we have our own medication. I wanted to just know, in order not to overdose this woman. But she told me there are medications. She had no right. She had no. I said, Mama, this one. After she left, I said, this thing, don't take it yet. I don't know the content. Let me give you our own first. But if there's an antibiotic there, then I'm interested, because I don't want the wound to break down. So I talked to the doctor. I said, please, what are the pills my mother taking? I want to know. Then I told me one of them was antibiotics. I said, good. We have to use 3 identifiers before you pop your pills into the patient. Okay? You want to, when you get to the patient and you want to explain this procedure. As a matter of fact, every procedure must be preceded by explanation, because you're not dealing with robots. Explanation. Simple courtesy. Mama, good morning. How are you? Did you sleep very well? She will answer all these things. How is your pain? What is your pain level now? Assuming 10 is the highest and a 0, no pain at all. Where will you put your pain? She will tell you. That will enable you know what you are going to give to this patient PRN, isn't it? I know that in this part of the world, we don't have, every patient is supposed to have a name tag band that contains their name, date of birth, hospital number, all of that. Do we do that in UBTH? No. This is a teaching hospital. What are we teaching the young ones? What are we teaching? So this, we are humans. We are not above errors, right? That is why when you bring in a pill, as a matter of fact, you are not supposed to remove the sachet of the pills in your workroom and take it to the patient. When you get to the patient bedside, that is when you open them up, because now you have the labels in your hand, and you know, so that when you ask me what did they take, then I know what to tell you. Because I'm not going to be able to remember 9 pills peeled in a cup. I will let you know. You're going to be taking this pain medicine called Panadol. This one is the antibiotics for your infection. You see, you are educating the patient what they are taking it for. So if the family member shows up later, she will be able to tell them they gave me pain medicine. They gave me something they call antibiotics. All that. So, what is your name? Formally, she will tell me her name. Your date of birth, she will tell me her date of birth. I'm going to be matching this with the information I have on the computer. If it doesn't match, I'm not going to give her the pills. We're going to have to change something before I give them the pills. Okay? But if you peel your medication out there and at times they carry 2, 3 at the same time, I'm wondering to myself, how do we know if it's Peter, James, and John that has that one? What happens if what is in this cup has something that you are allergic to? And I'm about to give you your pill, somebody just distracted me, right? And then when I finish all that cell phone conversation and all that, then I still give you the pill. What if I switch? We are humans, we can make errors. This is how we are killing our patients in this country. If an institution like UBTH does not have method of identifying your patient, please, let's do something better. We need to change that, because we don't want to kill our patients. I know that if a patient dies from a complication, nobody is accountable. Do unto others. So the provision number 2, we were talking about the American Nursing Association Code of Ethics. Provision number 2 has to do with the nurse's primary commitment is to the patient, and the family members and the community. The doctors, they are not staying with you 24/7 the same way you are staying with the patient. You want to be an advocate. Now this doctor comes and he says, oh, because everybody preoperatively gets cefazolin 1 gram just to prevent infection. They don't remember the entire history of this patient, because you are the nose and the eyes and the ears of this patient. You are there to quickly say, oh, Dr. X, no, I don't know if we should be giving cefazolin because this patient is allergic to penicillin. You have to. Oh, really? Oh, all right, okay, let's change it. Let's give Cipro. You see your role? You are so important in the healthcare. You have to fight for your patients. Don't fight against your patient. You are a patient advocate. Please. This is what I'm going to read here. I know it's going to be, what do they say? How do they speak that in counterintuitive? It says that if there is a witness or recognition of questionable healthcare practice, it is important that the patient be protected by reporting any misconduct or potential for harm. I don't know in this part of the world if, for example, Madam Provost and I, we are the nurses on the unit, and she makes an error, and I witnessed it. Okay? Listen, we may be 27th intake together. Okay? She may be the provost of this community here. It doesn't come to, it's not that, all of that is not important now. What is common to both of us now is the patient. Okay? So our 27th intake and all those provost things, we got to put it aside. As far as we are concerned right now, you just made a mistake. And this patient's life is in danger. I am obligated to report it. I have to report it. It doesn't matter what relationship I have with her. That is how it's supposed to be. But here, we are covering up. We're covering up each other. Why? Do unto others. Why are we doing that? We can't do that. Same thing with student nurses. If you cover up mistakes, I hope you have a conscience that when you go to bed, you won't be able to sleep. Because that's what the internal police officer is supposed to do to you. Okay? Roll off that load of your life. Report. The reason for reporting is not because they want to sack you. It's a systemic error, and we need to fix it. Okay? That is how it works over there. They keep transforming the hospital setting by learning from our mistakes. Over time, we're not going to make that. As a matter, they will organize seminars like this and begin to teach us and begin to put plans in place that will not replicate, the previous mistake. So I don't know how we're going to get past that. So if you need a transformation in the system, we're going to have to report our mistakes so that we can fix it. Are we going to be able to do that in this environment? That is why this lecture is a spit in the ocean. So no nurse should be able to administer nursing care if you are under the influence of any substance that will impair your action. I think in this environment, that's one thing we do very well. People don't smoke on duty, they don't drink alcohol or drugs. I don't know if that has changed. Coming back. So, provision number 4, the nurse has the authority, accountability, and responsibility for nursing practice, makes decisions, and takes action consistent with the obligation to provide optimal care. That will be governed by your internal police officer. We do have autonomy or authority as a professional, but we should not use our power. This is what I found in the nursing here. We are using our power to subdue the patient. So we are not supposed to do that. Provision number 5, the nurse owes the same duties to self as to others. So that is almost looking like the second greatest commandment, love your neighbor as yourself. So if you know that you cannot eat your breakfast unless you do your oral care, then the patient on your bed, you got to be able to do that. But those intimate nursing care are dwindling away. Or we roll it over to patient families, right? It looks like that's what we do now. We must have a patient family by the bedside. Who has taken over our patient, our nursing care? Is that what we're doing? Okay. Because we cannot make the patient. They can do it. I am so happy to partake in my mother's care. But you shouldn't roll it to me. I should do it with joy. So, personal growth is important. Again, we should not see and regard, and just classify your personal growth in terms of continuing education in form of just letters. It's supposed to cause your personal transformation and your nursing care. People should be able to see it in you. That's code number 6. The nurse, through individual and collective effort, establishes, maintains, and improves the ethical environment of the work setting and conditions of employment that are conducive to safe, quality care. I don't know if we have a condition of employment written somewhere. I don't think so. Because if we do, and somebody reports your misbehavior, then we're going to pull out that condition of employment. I don't know what we sign now to assume our offices. So if you violate any one of them, do they even write people up? Do they even do that? Like, you do something wrong, I write you up. We take it to the supervisor. There's something called a first warning and second warning, and then the third one, you are gone. Do they even sack people in UBTH? Other than just to wait to retire? So we need to start enforcing that, because if I see that you are sacked, then I will wake up and start doing what I'm supposed to do. But who knows, man will not let them sack them. Provision number 7. The nurse in all roles and settings advances the profession through research and scholarly inquiry. So this is the challenge, Madam Provost. Your students, they're going to have to start partaking in research work. That's one of the ways to transform all this process. Those research work, whatever their recommendations are in the end of their scholarly research, we need to be enforced by UBTH management to be able. It's not just enough to do it in form of paperwork, present it, and leave it. You understand what I'm saying? So in the end, I'm going to be able to show you some things that our nurses need to take, pick them up and use them. So that is the 9 provision for the Code of Ethics by ANA. The profession of nurses collectively, through its professional organizations, must articulate nursing values. So we have organizations within UBTH from the nursing department. Yes. So whatever we do in those departments, we're supposed to package it together, channel it. Our board of nursing, they should be our rep at the state level or federal government level, representing our interests. So whatever changes they need in the nursing, they will have to effect it from there and pass it down to you. Now, you and your management will become the police officer to put it in place. Okay? If any student does anything, disciplinary action. That is how we all get it. So you become answerable to those in the higher authority. I wanted to stick this in here. Are we still familiar with the nursing process? Are we using it? It's very crucial. Okay? The nursing process, assessment, diagnosis, planning, implementation, and evaluations. If we make this central to every care we give to our patients, will never go wrong. That is our roadmap. Okay? We need to continue to enforce it. I call this the 3 C's, central core of the nursing profession. Who is in the middle? Let's go practical. Assuming nobody is sick in the hospital. Assuming nobody is admitted to the hospital. You don't have food to eat. No work. So don't you ever think that you are doing somebody a favor. They are doing you a favor by being sick. Right? So but for nurses to then begin to carry themselves and think they are the alpha and the omega, it beats my imagination. Because these patients are the ones feeding you, actually. If only they know. I wish I could just go and stand by the door of every ward and say, Madam, let that nurse know, say, now you they feed them. But it's true, they are the ones feeding you. If we don't generate income, maybe that is why those people are very efficient over there. Because it's a business. So that alone, it should give you the conscience that if this patient, if I don't treat her very well, my business is gone. Over there, if you don't meet up with the standard, when a patient is being discharged, they will give them assessment of the care they received. Better be praying they don't mention your name. As a matter of fact, they don't have to even ask for your name. We all have to wear badges. Do we still wear that? We have to wear a badge. If you're an RON and whatever that thing is, you put it there. So listen, you have to tell the patient, good morning. You introduce yourself, who you are. So you can't even hide. Okay, so when they want to complain about you, it's right here. You can't bribe it away. You see? So they are so central to our care. So why do we treat them like robots? Let's be realistic. Why do we treat them like robots? Why don't we explain to them what we're doing to them? So please, without your patient, you're not going to eat. I have 4 scenarios that I want to, practical application to this ethic of nursing that I just talked about. Scenario number 1. In 1983, a baby was born at home under traditional birth attendant. She was brought to UBTH with severe jaundice from abject poverty. The mother could not afford to put this patient under phototherapy or exchange blood transfusion. So the mother was advised to take the baby home and bring the baby at intervals for phototherapy. Unfortunately, this child got complicated with kinniтерus. And then developmental delay set in. He didn't walk until about after 5 years. He became the disabled child of the home. His speech was garbled. And he was also having seizures at intervals. That was just jaundice. Curable disease. In 2010, at the age of 26, this child wandered away from home. In 2010. The mother is about 79 years old now. She's still looking at that door to their home. That someday, his son will walk through that door to their home. But she's still waiting. She's almost 80. He hasn't come back. So, it's your turn. You are going to have to answer this based on what we already talked about in ethics. Where did we go wrong in these clinical scenarios? My students, I know that you are the one to teach us today. I'm going to put you in position. So be ready. I'm going to give them the microphone at any time. Okay? Just be ready and be thinking now. What went wrong with this clinical scenario? What went wrong? What went wrong? Somebody needs to tell me what went wrong. Speak louder so that they can hear you.
Baby had yellowing of the eye and not able to
It's okay. My question is, I don't want you to go physiologic, okay? I want you to go into care, like what we've been talking about, ethics in nursing, okay? That's what I want. What went wrong in our care of this patient? Don't do physiology, okay? We all know what physiology is. What should we have done differently in this case, based on what we've been talking about? That's what I'm talking about. In this scenario. It's okay. That's what they do with us over there. They will pick on you at any time, so you have to be ready at any time too. Okay? So, how many people have died in this country because of abject poverty? You see, over there, this over here is money for hand, back na ground. My cousin died because they did not have the money to buy blood. What has that got to do with anything in medicine and in nursing? It has nothing to do with anything. I don't have to produce gloves before you treat me. I don't have to produce blood. The thing is, you save me alive first, and then come and demand for your money. That is how it is. See, this is our problem, because they are from abject poverty. Just look at the life that happened here. You see, what if I tell you that is my brother? That's my brother. He's not back for jaundice, a curable disease. I'm determined to treat my patient with dignity. I will do whatever it takes. As a matter of fact, I don't know if you saw my credentials over there. I am the founder of Love Your Neighbor Rescue Mission International. I am so determined to make sure that I take care of my patient. My experience with that is one of the things that birthed Love Your Neighbor Rescue Mission International. As far as I'm living, I will not allow something like this to happen. It won't. It's a personal decision that I've made. Okay? For my brother to be missing at the age of 26 and we can't find him. For my mother who's still alive to be in pain right now. That it doesn't matter what I do now. She cannot forget that child. 26 years old. That child was not even supposed to be disabled. Phototherapy, exchange blood transfusion would have taken care of that. That is where we are in our healthcare in Nigeria. Scenario number 2. I kind of touched on that already. As a matter of fact, what I want to touch on this scenario is a 77-year-old woman was admitted into the surgical ward with history of type 2 diabetes, hypertension, diabetic ulcer. She was scheduled for skin graft in UBTH. She spent 10 days in UBTH with for surgical treatment. Nurses were advising her to go and see the consultants privately and bribe him if she truly wanted her surgical treatment. She was never seen by this consultant. She got fed up, paid the hospital bills that she was not treated for, and discharged herself to receive care from a private hospital in UBTH. Really? Nurses. My question was, who was that nurse that started telling her to go? Are you being an advocate like that? Advising her because of the tradition of UBTH. If you don't go and see the consultant, you're not going to be able to get treatment. And true, she did not get that treatment. And she had to pay from her pocket for the admission, that 10 days. Come on, guys. Do unto others. What happened? What if I tell you this is my mother? That was my mother. What happened? Where are we taking nursing to? How can we do? How can we fix this problem? So that consultant does not have a superior that we can report to, or every one of them, or many of them have private practices. If you cannot fix it in UBTH, they take it to their own private institutions, times 2 the price. Okay, these consultants, don't they have bosses ahead of them that they are answerable to? So how do we, this is why I told you that this lecture is a spit in the ocean. Do you see our problem? So I had to go spend money on my mother outside, and she got better. You see? So, Madam Provost, what you told me about, how nursing is falling and all that, yes. What about the people here? They are untouchable. The people here are untouchable. Okay, I have a rep here from the management. She said they are not reporting it. I just heard that. She said you are not reporting these issues. So why are you not reporting these issues? So that we can effect the changes that we want. What are you scared of? They're going to fire you or sack you? Fire. See, we are afraid that we are going to be sacked. That is why we are not reporting it. But that is wrong, our rep said. Please, you need to share this with me. Because, please, come on. Whatever your fears are, listen.
She made a statement. If you see something and you don't say something, you are also accountable. Let me tell you, I'm with this man, and I get reports from consultants. When they bring a case, I pull it up. I call the doctor immediately and talk to their conscience. That's what I do. Would you be happy? Because sometimes they give horrible excuses. Flimsy excuses, I'm sorry to say, they are my colleagues. But if we do not call ourselves to order, who will? So, nurses that are custodians of the wards, they don't report. I'm sorry to say. If you disagree with me, challenge it. No nurse has ever complained about poor treatment of any patient. Most times I get it from other colleagues. And once I get it, my duty is to call the person involved and talk to the conscience. But sometimes it's an oversight. But by the time you talk to the person, then they will move. So please, let us form the habit of reporting ourselves. It's a way of auditing ourselves and making ourselves better. Yes. And then it's not your place to be encouraging patients to leave the care here because it's better outside. When anything goes wrong, they will never forgive you.
Thank you, madam. So please, henceforth, let's do our part and become patient advocates and see the changes come to pass that we are craving for.
You can send an anonymous test. Any anonymous test you see every day, you act on it. You don't have to put your name there. His number is everywhere. Our numbers are everywhere. Send a test. Stay there, the thing is happening. By the time you go there and investigate, you will find out. So that's justice. So if you are afraid of being victimized, send an anonymous test. Thank you.
Thank you, madam. You should know, let me tell you, whatever we are doing here today is recorded. What she said is recorded. Okay? So, as they will say over there, take it to the bank. What she said is engraved. You can use it. You pull the information anytime to back up. If anything negative, come back to haunt you. Okay? You take it to the highest level. and take that information. So that is inscribed on soul. Scenario number 3. In 2021, in 2021, an 86 years old man with no prior medical history collapsed in his home and was rushed to the hospital. God, what is that? They admitted him in coma and received a diagnosis of cerebrovascular accident, which is stroke. Patient was in bed half naked, head of bed flat. Initially, no oxygen given. IV Heplock without continuous IV infusion was started. His urinary output was very dark and concentrated like coffee. Few hours later, he was gasping for air and he was given oxygen via simple face mask and head of bed flat. At this time, IV fluid was commenced. He later died 24 hours after admission. This is the man we're talking about in UBTH here. He was the chief in his own community. We just upgraded our care now by giving him simple face mask. See, look at his urine, how concentrated it is. Okay? He's struggling. 24 hours later, he died. This is the best we can do in UBTH. Is that the best we can give as nurses? Is that the best we can give? Are we going to change things around or not? And what if I tell you this is my father? This is how my father died in UBTH. My school of training. A teaching hospital. That is the best we could do. Right there. How will you feel if you are coming from an advanced world like that? And I'm a nurse, I'm trying my best to make sure I give my love and tender loving care to my patient. And within 24 hours, this is how your father passed. How will you feel? How will you feel? This is so pathetic. This is so pathetic that I just want to go onto the rooftop and be screaming that we need to change everything about nonsense and medicine. Somebody's urine is that. At least you then manage to put a hep lock. Can't we hydrate? Is there a medical doctor in this place that can just tell me at least the basic thing that we should be doing for this patient? Head up! What happened to Simon Fowler and Fowler position? I thought I heard that word when we were being trained. Look at the patient. This is not even a non-rebreather mask. A patient with CVA. Come on, guys. We should. I don't want to start talking about the medical care. At least I know what to do if a patient comes to me with CVA. A nasal cannula for the patient. So we are so down like this in UBTH. People used to refer people to UBTH for care. This is just my personal experience or experiences. It's very painful. Very painful. I still have a mother alive. I hope she won't go this way too. But it doesn't matter. He doesn't even have to be my father. This can be anybody's father. I just wanted to show you all that. And I want to round up. So we'll go back to the slide. The last one was, I'm not going to really spend too much time on this one, but I just want to make a connection to that too. A 79 years old woman, after surgery, she was supposed to, she's diabetic, her blood sugar was supposed to be tightly controlled. We all know if you don't tightly control a patient's blood sugar, when they have surgery, the wound is going to break down, okay? So, the nurses were very careless about her blood sugar, even though she paid ahead of time for the glucose monitoring. But they checked the patient's blood sugar, it was 150 something, 157. So the nurse, with a nonchalant attitude, came to the bedside and said, "Madam, you never chop?" No go chop. So the woman said, no, the family member now said, we are waiting for the insulin. Oh, you get diabetes? Yes. Okay, make her go check. Then she came back and said, well, the doctor said that we should give you the insulin when necessary. I'm thinking to myself, what do you mean? Sugar is 157. Is it not necessary? Why are we not giving the insulin? She said, they didn't. You see, the fact that the nurse does not even know her patient, for me, that is a problem already. You want to know your patient inside before you come to my bedside. Please look at my record so that you know what. I shouldn't be the one telling you that I have diabetes. You should get your act together before you come to my bedside so that when I ask you questions, you'll be able to articulate everything. Right? So that was so surprising to me. So that was, again, this is my mother. And I stood up and I said, please, you can do everything else. That wound cannot break down. Because I've been too patient. I was not going to say a word. But this one, sugar, no. I said, this lady, she's taking this amount of insulin, this amount of 70-30 and regular, and metformin. Oh, no, we had a patient here before. She didn't wake up. That's why they started writing as necessary. I said, listen. If you had an issue with another patient, again, remember, the patient knows her body more than you do. So now I'm telling her, listen, she's not going to go hypoglycemic. I'm here. I'm going to monitor the sugar. I said, when the doctor came, I said, listen, I want to take over the blood sugar of this woman. They can do everything else. I want to do that. I have everything with me. Please, let me do that. So they gave me the go-ahead to monitor my mother's blood sugar. Because the very first insulin they gave to her, they did not add the regular human R on top of it. Her blood sugar was 200 and something. Hey, I said, no, this is not going to happen. I will speak now. I'll be too patient. The lesson from here, please know your patient. Okay? Know your patient. And know the parameters that the doctor wrote down for your sugar coverages. Because the patient is the one suffering, not you. Okay? So, we have questions. Do we honestly want to effect changes in nursing practice in UBTH in order to meet our international standard? This is a transformative lifetime journey. It's not a one thing. So, Madam Provost, this is going to outlive you. Our young nurses coming up, if they stick their feet down, they may be able to effect the changes that you want right now. It's not possible. It's a spit in the ocean. It's lifetime. It's a pyramid. There is a pyramid that is involved. Nursing school is at the base. Okay? On top of the peak is our CNO, the Chief Nursing Officer. She's the one liaising with the department, the CMD people. Okay? So it's above you. But all you can do is to make sure that you train your nurses to be conscientious, just the same way Ms. Agawa taught you and I. Hopefully, when they go out there, we pray they practice nursing. Okay? There is something called annual competencies over there. This is one reason why we are not changing. Every year over there, all the changes you are looking for right now, patient attitude, this and that, there's an education department that every one of us every year, one is waiting for me right now. You have to go through these hours, maybe minimum of 8 hours of competencies that you got to. Your employment is contingent upon that. If you don't go do it, next day you come want to try to clock in, you can't clock in. They tie it to your paycheck. So it is mandatory. You must go through those trainings every year. So whatever you think you want to change, you may want to start at that level. Let your education department put all these things together. and make these nurses to go through them every year. If they don't go through them, they can be sacked. You can give them the first warning, they call it, the verbal warning, written warning. The third one is sack. They will all sit up and they will do it. Now, after going through those competencies every year, if they now do anything in the clinical arena that is contradictory to what they learn, then they're in trouble. See, so that is how it works, you know. So we need some disciplinary actions to be put in place. I don't just want us to be looking at the young nurses and think they are the problem. We need to come from above. If we come from above, and she stands there and starts saying, oh, she's coming. Those are the kind of respect I want, not just running around like that because she's coming to the unit. No. Let her policies in place be the voices of the nurses. Because if the head nurse of the unit complain about the nurses that just work overnight, I remember when I was a student nurse, I did my clinical rotation in the pediatric, the L&D unit. That night, I can never forget this. We were doing night shift as a senior, I think I was a junior student nurse. My registered nurse asked us to mute all our babies by putting pacifiers. Pacifiers. We taped pacifiers on all the babies' mouth. Yes. I'm not exaggerating this. You know, the reason why I remember this is that I don't even remember who the nurse is. So unfortunately for us, the matron that runs on night shift, she just walked in on us. And our nurse was on break. And we were still nurses. So we worked and every baby had a mute button in their mouth. Oh my God. She could not believe it. But you know the amazing thing? This woman continued to work in UBTH. Is that not enough to sack the person? Is that not enough? Is that person, I'm sure she retired now because I'm almost retiring. So I'm sure she retired with benefits. And she will begin to eat that benefit until she dies. That's what we do. Babies, we're all muted. That is the practice. I'm sure maybe that matron reported her. I'm sure she called her man of influence who made that call from his bedroom and said, what are you doing? If you are not careful, you will be the one who will sack. Yes. That's it. So, are we truly ready to practice this kind of nursing that I've been describing in UBTH? We practice human caring. We listen to our patients' cries. Okay? We place our patient at the center of our planning and decision making. That is, they are part of our decisions. We meet each patient where they are at the moment. This very moment. What do you present to me? You know, I'm not going to use in the yardstick of measurement, I'm not going to use the same with you. Individualized care, they call it. Individualized care. Okay? We connect with each patient, with each person by valuing their unique needs, spiritual beliefs, and personal choices. So you are treating this patient as a whole. Okay? We always seek to earn person's trust. Let them know. If a patient can trust you as their nurse, oh my goodness, that is a great thing you've done for that relationship. So, can we pursue and apply new knowledge, evidence-driven practice, and model care as a means to exceed expectations? So those of you that go back and advance your training to get all those credentials behind your names, how can you use that to transform nursing? Not just for promotion and retirement. Can we utilize research as the basis of our practice? Let's use our student nurses to dig more into research and then bring the result to the management and effects and changes. Can we engage in continuous quality improvement? Like that CEUs I was telling you about, you know, that is how we can do that. Can we embrace new technologies to promote the delivery of care? I don't know what you all do right now. Maybe you are still doing paper charting. So you have EMR now? Okay, it's evolving. Very good. We need that. Because that is an evidence to, people can easily alter things. When you go there, that will document anytime you go in there to go alter any documentations. In real time, anyway. So yeah, we need that. That would really be good. So can we be cognizant of the cost of care and engage in initiatives to enhance value? Like I said, my mother, after paying for the 10 days here without care, she went back and continued out there. So we should be thinking, not everybody can afford to do that. The patient will end up dying while we are waiting for one consultant to leave his office, or to come out, find them. So let's treat this patient as a whole, holistic care. So the outcome, overall values would have to align with the following values. If we can take this and say, student X, we want you to research integrity. How can we push that into our nursing? So whatever they come up with in all of this, innovation, excellence, stewardship, research into that, and then package it to your head of department in nursing schools, and then give it back to the management, and so that can be a way to start, So that becomes the standard of care in our institution. Thank you all.
Thank you very much. Let's give her 3 goza. Goza. Thank you very much. We are grateful for this wonderful lecture. Students, did you listen attentively? Yes, ma'am. Are you ready to render care in the manner and way she has described it? Yes, ma'am. I hope you will be willing. And if you are willing, God will help you. Yes. Just have that willing mind. The mind to care for people the way you want to be cared for. You may not be rewarded. Patient relation will come, they will still shout at you. They will still tell you that you have not done anything. But try. Your reward is not only here on earth, but in heaven. Do it to the best of your ability. Lecturers, are you ready to teach the student to give tender, loving care? Yes. We should also try and put in our best. Are we ready? Yes. Lecturers, are we ready? Yes. The students said they are ready to learn. We should be ready to teach them too. And if we all put our hands together, we can take nursing care in UBTH, in Nigeria, and the whole world. There will be improvement. We can move it forward. Thank you very much for coming to listen. So, CMD representative, want to say thank you very much, ma'am, for your useful contribution and for finding time out of your very busy schedule to be with us. We appreciate you, ma'am. We appreciate all of you. Thank you very much for coming. Thank you.
Thank you so much.
I've been asked to say a word. Great nurses. Okay, enhance that care. So I just want us to remember that caring for patients is teamwork. You are as valuable as you think you are in a team. If you say you do not have value, who am I to say you have value? The choice is yours. Good morning. Thank you very much, ma'am. That brings us to the end of the morning session. Thank you very much.